Hi, this is Bob Harrington from Stanford University on the heart.org at Medscape Cardiology. You know, over the last few months, there's maybe the last year would be fair to say, and certainly intensified in the last 6 months since the American Heart Association meetings, there's been a lot of discussion in the cardiovascular community about cardiovascular prevention. And really this came, I would say, mostly to the forefront in the last 6 months as there was intense interest in the prevention guidelines. But we also have the AHA 2020 impact goals. We have the Million Hearts program, which is nearing its halfway point, by the way. We have the United Nations talking about World Health Organization forums on non-communicable diseases. And to me, what this sends the message is that all of us in the cardiovascular community, whether we're talking the practitioner community, the broader public, as represented by things like the CDC and the AHA, and in fact those interested in global health, all see the burden of cardiovascular disease as a major public health issue. In fact, one might say it's a major public health scourge. And in our prevention guidelines, which we've talked about on this show, we have tended to focus on the risk assessment. And we've talked less about therapy, although it is important to note that in our prevention guidelines, one of the documents is really headlining the topic of lifestyle modification. But I suspect, like many of you in practice, find the issue of lifestyle modification quite challenging when taken into the actual practice of medicine. We all talk about it. We all say something like we really focus on lifestyle modification when we have our patients who are at moderate to high risk of a cardiovascular event. But we don't, I don't think, do necessarily a great job. So today I'm really pleased to welcome to the show Dr. Stephen Devries, who is the director of the Gaples Institute for Integrative Cardiology. Dr. Devries is a preventive cardiologist with a lot of experience over the last few decades of really focusing on prevention strategies in cardiovascular disease. He's also currently an associate professor of medicine at Northwestern University in Chicago. Steve, thank you for joining us today on Medscape Cardiology.
It's a pleasure to be with you, Bob.
So let's jump right into it, Steve. And I want to really explore this issue of lifestyle and what we can do both for and with our patients from multiple perspectives. But let's sort of set the stage for our listeners. Integrative cardiology. I also note, by the way, that you've co-edited a textbook on integrative cardiology with my friend Dr. Jim Dallin, who I had mentioned to you off the air was the chair of medicine when I was a medical resident. So it's nice to see his name there. But I'm wondering if you can tell the listener audience, what is integrative cardiology?
Yeah, Bob. Integrative cardiology is the intelligent integration or combination of natural approaches to health, defined as nutrition and lifestyle, combined with the best in conventional medicine. All the medications and procedures and the guideline-based therapy are included, but also I think perhaps a larger scope, maybe a larger palette of treatment options related to nutrition and lifestyle and activities that can empower patients from their own lifestyle. And really that's integrative cardiology. Many people consider integrative medicine to necessarily include the use of supplements and kind of unproven strategies. And I don't look at it that way at all. I really think that, evidence basis has to be there for whatever we do. But I think there's also a wide range of evidence to support the emphasis on lifestyle and nutrition that isn't applied as strongly as it could. And that's kind of the goal of integrative cardiology.
That's a fantastic summary, and you might imagine that I both appreciate and enjoy you stressing the issue that this is evidence-based. And our listenership again will appreciate that. It was interesting to me, Steve, that when the prevention guidelines were rolled out by the ACC, the AHA, and the NHLBI last fall, there is a document on lifestyle, but it seemed to be relegated to the second part of the conversation, although in the approach to the patient, it's always stressed as the first part of the conversation. But what got the attention was not lifestyle; it was everything else. How do you approach it? And what I mean by that is I'm looking for help for our listeners, including myself. How do you approach the issue of nutrition and lifestyle with your patients? And let's talk specifically about our cardiovascular patients. So the patients that cardiologists see, many, if not most of them, have diagnosed disease. So let's take that group first before we get to the primary prevention group.
Well, whether it's primary or secondary prevention, kind of my vision is that currently cardiologists are acknowledged as experts in the treatment of cardiac disease. But I think the future vision that would be great to look to is where cardiologists are dually recognized, both for expertise in prevention, be it primary or secondary, as well as for treatment. So I think that really the focus, as you said, when the guidelines came out, was on the statins and the indications for them and the calculators and so forth. But I think, as you exactly mentioned, we all say that, lifestyle is kind of the foundation of health, but our practice doesn't always support that emphasis. And that's where I think a lot of attention needs to be paid and where there's tremendous opportunities. And, in so many studies, you can barely not go to a conference and so forth where the final sentence is, we need more research on this topic. And although certainly there are areas in nutrition that are controversial and need a lot more research, there's also a tremendous amount that is very well established but not put into practice. So I would enjoy the day when guidelines are released and the focus on lifestyle is equal to, if not eclipsing, the focus on what to do with medication. An interesting study came out just a few months ago that showed that from a group of individuals who were prescribed statins and then a similar group followed that were not prescribed statins and had lesser cholesterol problems, but they looked at the follow-up over 10 years, and they saw that the individuals who were prescribed statins actually consumed 10% more calories than the non-statin users. And at least, although it wasn't proof, it kind of raised the suspicion that I think many people feel is that when statins are prescribed, there might even be a subtle implication that, there's a green light to kind of be more liberal with the diet and it doesn't matter as much, now you're on medication. And kind of a more integrative approach says, the statins are incredibly important, when given, for the higher risk individuals, but let's address the nutrition and lifestyle to a degree equal to that of the medication. We're really focused on compliance with statins and getting people on them, but compliance with not compliance, but attention to diet doesn't get stressed nearly as much. And there was an article that just came out in JAMA last year that showed that among 17 risk factors, nutrition was the number one for U.S. death and disability. So it's, looms, even above, all the other terrible things that we need to work on, smoking and physical inactivity and so forth. Nutrition probably is the number one target. It's the low-hanging fruit that we really need to focus on.
Well, I like your analogy or your visual with low-hanging fruit, because it is Salim Yusuf showed in some of his recent epidemiologic work around the globe that the decreasing amounts of fruit and vegetables in our diet, along with tobacco use and physical activity, are really three of the key lifestyle aspects that raise the risk of cardiovascular disease. And I, like you, found great interest in that article about the 10% increase in dietary indiscretion, if you will, amongst the statin users. And more than once, I've been to dinner with even colleagues who as they order their dinner, say, "Well, I'm not worried. I'm on my statin," sort of, tongue in cheek. But
right.
I don't think that that's an unusual sentiment. Tell me what your diet of choice is. I'm guessing heavy in fruits and vegetables, low in saturated fats. But I wonder if you could, help the practitioner a little bit. Give some specifics about the sort of diet that you think is evidence-based and consistent with an approach towards integrative cardiology.
Sure. I think, in kind of the executive summary would be a Mediterranean-style diet, which is, as you mentioned, heavy in vegetables and fruit, whole grains instead of refined, and more fish and less red meat. For the cooking oils to be predominantly olive oil and canola-based oil. So that's kind of, in a nutshell, if you will, the mainstay. But I think just to speak a little bit about some of the distractors that have been out. There's been a lot of controversy about the role of saturated fat. Is it the big problem that we made it out to be, and was it just that we were cutting down on saturated fat and replacing it with sugar? And, was that, trading one ill for another and with no net benefit? Probably all of the above are true. But I think that, when we focus on individual nutrients, we can really lose the path. And the idea is that we're consuming, we don't consume saturated fat, we consume pizza. We consume, desserts, snack desserts, cookies, and cakes. So if you focus on individual nutrients, I think it can be very misleading, such as, it's interesting that when we're talking about saturated fat, among the top 5 dietary sources of saturated fat in the United States are pizza, grain-based desserts, and dairy desserts. So it may be partially the fact that they are high in saturated fats is the problem, but also the other things that come with the pizza, which is the high salt content, the high carb content, and so forth. So I think, what can clear up a lot of confusion for people is instead of, going from nutrient to nutrient and is it saturated fat or is it the sugar, probably it's a combination of all of them, and it's very complex. But if we go to a whole diet approach, like a Mediterranean-style diet approach, I think it really cuts through kind of being misled and being led astray by focusing on nutrients and by looking at whole diet patterns that have been proven to be beneficial. And I think that's the beauty, that this is evidence-based. The Lyon Mediterranean Diet Study, which was secondary prevention, showed a whopping 72% event reduction in the Mediterranean-style diet group compared to the kind of just watch the fat intake group, which was the control group. The Predimed study that just came out last year showed a 30% decrease in vascular events, which was a primary prevention trial. So we've got, I think, really strong data to look at a whole diet approach. And I think if we focus on that arena versus, is it this nutrient or that nutrient, we can be in far better shape. The same thing with the salt controversy. Instead of trying to decide, which of the cut points is the most accurate one, if you look at the U.S. dietary intake of salt, the food which is number one for salt intake in terms of the amount in the U.S. diet is amazingly bread. Most people would think it would be something much saltier like pretzels or soup, but we eat a lot of bread, and bread has a good amount of salt. And so bread ends up being the number one dietary source of salt intake in the United States. I mean, is there anyone who thinks that we should be eating more bread than we currently do? Absolutely not. Pizza is also high in that. No one thinks that we should be eating more pizza. So instead of wondering about which cut point for salt, I think it's more instructive to look at the foods that contribute most to salt in the U.S. diet or saturated fat or whatever, and to look at them as a whole. And that, again, is the beauty of a Mediterranean-style diet. It looks at whole foods and proven food groups that have been shown to be beneficial.
Steve, I think that's a nice holistic overview of thinking about is I think you've nicely put it, the big picture as opposed to focusing and obsessing about the individual. Let me just ask your opinion quickly on a controversy that we've talked about on this show before, the so-called Atkins diet or the paleo diet. they get a lot of press, and there are many people who say, look, the only way I can really lose weight is if I focus on taking all carbs out of my diet and really focusing, and I replace it with protein. What's your current thoughts? Because the data on those sorts of diet is mixed.
Yeah, there is no long-term data on either of those diets. So, the fact that over, a period of a few months or even a year, you might have favorable impacts on some biomarkers, I don't think is the end goal. I mean, as clinicians, we're all interested in patients living longer and better, and really the endpoints that we really care about that matter have not been shown in those diets.
Right. Do they live longer or feel better?
Yeah, exactly. And, the interesting thing about diet, unlike drug studies, is that when you're focusing on a diet that either is focused on exclusion, a low-fat diet, or one that promotes something like a high-carb diet, those diets, in addition to the area of focus, the low-fat or the high-carb, also have to look at what you're replacing, the thing that you're taking away, what's being replaced and what's being added. So you never, if you're keeping, most people when they change their diet, unless they're trying to intentionally reduce the caloric intake, which is a good goal for many, but for others, generally if they're adding or subtracting something else is also being substituted to take its place. So you never, when you're looking at a low-fat diet, usually you're also looking at a high-carb diet. So it's complicated that way in terms of trying to really understand what you're doing with the diet. Unlike a drug study, you can either add the drug or not have the drug. But for diet, since we all tend to eat, the same caloric intake generally every day, if we're going to take something out, we're generally going to put something else in. And the question is that a net benefit? So even diets that may not be an optimal diet, if you're replacing something that's even worse, you may be in a better shape than you were before, but is that an optimal diet? Possibly not.
And the sustainability, I think your point is well taken. Steve, one of the things that all of us face is that this is, from our patient's perspective, quite difficult. I mean, we have, as you know, not just a national but a global epidemic of obesity, of the increasing incidence of type 2 diabetes. If you look around the globe and look at the maps, heat map, if you will, of the rising incidence of diabetes, it's frightening. It's as frightening as the worst of any epidemic that you've seen around the globe. How do we help our patients with this? We're all talking about it. We all believe that it starts with nutrition and lifestyle, as you said, physical exercise, reducing or eliminating consumption of tobacco products. How do we help our patients? What sort of advice can you give both to docs and to patients about putting this into practice?
Well, one of the best ways, paradoxically, you might not expect this answer, but one of the best ways we can help patients is to first help ourselves. And there's some fascinating data that shows that for healthcare providers who change their own personal lifestyle, that they are much more likely to counsel patients with regards to lifestyle. So that's the first area, is self-care, not only for our own health, but because there's a great downstream effect. But then beyond that, one thing is to get a meaningful baseline and intake forms to have, more detailed questions about the diet included. And then, the idea is that everyone is busy, and busy cardiologists, may have only 1 or 2 or 3 minutes in a clinic visit to address nutrition. But I firmly believe that 1 or 2 quality minutes can make a huge difference. So even if you take in the visit, decide you're going to focus on one nutrition topic per visit. It may be if the patient before you is drinking a lot of soda, that it may be that those 1 or 2 minutes are devoted to the importance of eliminating sugar-filled beverages. Or it could be the importance of adding dark green leafy vegetables or dark red or purple fruits, which have been shown to be helpful, blueberries and strawberries. So just to take 1 or 2 quality minutes and to make them count. And most of all is to impart for the patient, which doesn't take long, the idea that nutrition is really the foundation of health, And even though patients are getting the medicine and they need to be on the medication they're taking, that the nutrition part is still, a priority that goes hand in hand with the medication.
Steve, that is, there are several things you said that I think I'll repeat because I think our audience should reflect on them. Number one, the notion of provide a heal thyself is a terrific one, and I would agree with you that as I look at some of my colleagues who I think are particularly effective in this space, they tend to be my colleagues who have adopted a very fitness-focused, nutrition-focused lifestyle themselves. So a point worth emphasizing. The second, I love the idea of taking 1 to 2 minutes of a visit and devoting it to a specific topic that's germane to that patient. It's something that we can all do, and it's worth highlighting. And then the final is think about nutrition as foundational for health. That's certainly a phrase that resonates with me, and I suspect with many of our listeners as well. So, Steve, I want to thank you for joining us here on Medscape Cardiology. This has been a terrific discussion of the notion of integrative cardiology, combining nutrition and lifestyle with the best in conventional medicine in an attempt to improve the cardiovascular health of all of our patients. Steve is the founder and director of the Gaples Institute for Integrative Cardiology. He's also an associate professor of medicine at Northwestern. Steve, thanks for joining me here today.
Thank you so much, Bob. It's been a real pleasure.